Muchas gracias, Douglas. Un placer haber escuchado tu presentación. Vamos a continuar y ahora tengo el enorme placer de presentar al doctor Kazuo Fujihara. El doctor es neurólogo y profesor del Departamento de Terapia de Esclerosis Múltiple de la Facultad de Medicina de la Universidad Médica de Fukuyama y director del Centro de Esclerosis Múltiple y Neuromielitis Óptica del Instituto de Investigación de Neurociencias en Toku del Sur, en Koriyama, Japón. Él nos va a hablar a continuación de la epidemiología y los factores pronósticos de las enfermedades del espectro neuromielitis óptica. Un verdadero placer, doctor, y bienvenido.
Dear friends and colleagues, I'm Kazuo Fujihara from Japan. Thank you very much for the kind invitation to this virtual symposium. I'm very much honored to be here today. I'm going to talk about the epidemiology and prognostic factors of NMO spectrum disorders. This presentation was prepared by myself and Dr. Ji Yun Ho of Penang General Hospital, Malaysia. Here's my disclosures. As you are all aware, a very important clinical features of NMOSD is a very high female preponderance. Up to 90% of the patients with AQP4 IgG are women, which is similar to SLE. Talking of SLE, some studies with type 1 interferon signature and whole genome sequence showed a link of AQP4 IgG seropositive status with SLE, but not with multiple sclerosis. So there seems to be a link between AQP4 IgG positive NMOSD and SLE. As for age at onset, the average age is around 40 years of age, but as you all know, some patients are older. This disease may develop in their 70s, 80s, and 90s. Recently, a number of epidemiological studies of NMOSD have been published, and we made a world map showing the prevalence of the studies of the disease. And as you can see here, the prevalence in white populations is around 1 per 100,000, but on the other hand, the prevalence in East Asians are higher, 3.5 to 5 per 100,000, and in Blacks up to 10 per 100,000. But even in Asia, some other populations like South Indians and Austronesians have a bit lower prevalence in comparison with East Asians. Let's take a look at the data in individual regions. Here's the data from Europe, and in the white populations, as I said, prevalence is about 1 per 100,000, and the annual incidence is about 1 per 1 million. Here's the data from East Asians, and as I said, the prevalence is 3.5 to 5 per 100,000, but unlike multiple sclerosis, there's no latitude effect observed. A recent Chinese nationwide incidence study showed that the annual incidence in China is 2.78 per 1 million. And also, they did not observe any latitude effect. In Black populations, there are some differences of the data. The study from Liverpool and Australia, New Zealand showed that the prevalence is about 1.8 per 100,000. But on the other hand, some other studies done in US, Martinique and Oxford, the prevalence was much higher, more than 10 per 100,000. But the number of patients are relatively small, so larger scale studies should be done. But these data may also suggest that the Blacks are genetically diverse. And unfortunately, so far, there has been no population-based study from the African continent. So the data from Africa very much awaited. Here's the data from Latin America. A recent study from Brazil showed that the relatively high prevalence of NMOSD, 4.52 per 100,000. And the MS-NMOSD ratio is 4 to 1. But on the other hand, a study from Argentina showed the ratio was much higher, MS21 NMOSD 1. What caused these differences? Probably two factors contributed to the high prevalence of NMOSD in Latin America. More specifically, genetic contribution from Africa and Native American are important. And the study from Mexico showed that Native American ancestry significantly contributes to NMOSD susceptibility in the Mexican population. In our clinical practice, of course, early diagnosis and appropriate treatment is important, and they contribute to reduced disability and improved survival. And prevalence is expected to increase over time. Annual incidence probably will remain stable over time, but more studies are needed to clarify the incidence. Another international group led by Professor Jort Illich of Southern Denmark recently published a systematic review of the epidemiology of NMO spectrum disorders, and they concluded that NMOSD is a rare disease worldwide, and there are variations in prevalence and incidence among different geographic areas. And there's a need to develop specifically designed epidemiological survey to identify genetic effects and etiological factors. If you're interested, please read this very nice review. Let's discuss MOG-antibody associated disease, or MOGAD. There are not so many epidemiological data, but here's a Dutch nationwide study. According to that study, annual incidence in the country is 1.6 per million. Please note that AQP4 IgG positive disease incidence in Europe is about 1 per 1 million. And the disease was more common in children than in adults. So it seems MOGAD seems to be more frequently seen than AQP4 IgG positive NMOSD in the country. By the way, a UK MOG cohort study showed that there was no racial preponderance. Some studies showed there were more MOGAD cases than AQP4 IgG positive NMOSD. As for hospital or lab-based studies, studies from Sri Lanka and Mayo Laboratory showed that there were more MOGAD cases than AQP4 positive NMOSD. And the population-based study done at Oxford showed that the prevalence of MOGAD was a bit higher than that of AQP4. So there may be more MOGAD than AQP4 IgG positive NMOSD, at least in certain populations. How about the MOGAD in Latin America? In Martinique, the prevalence is 1.6 per 100,000, and the study from Argentina showed that relatively similar numbers of AQP4 positive and negative cases, but among AQP4 negative cases, 1/3 of them were tested positive for MOG antibody. But on the other hand, in Brazil, MOGAD appears to be rare. So more MOGAD studies are needed to clarify its epidemiological features. There is an active NMOSD genetic research in Latin America, and there are many studies on the HLA associations. A number of HLA phenotypes are associated with higher risk or protection, but I do not go into the detail. Now let me discuss the prognostic factors in NMOSD. And this slide shows predictors of poor prognosis in MS, like older age, male sex, higher number of T2 lesions, T2 lesion volume, primary progressive course, higher relapse rate, and oligoclonal band positivity, and high levels of neurofilament light chain in the CSF and serum. And how about the prognostic factors in NMOSD? As for age, young patients have a tendency to develop optic neuritis at onset, while in older patients, onset attacks are more likely to be myelitis. And the young onset patients with optic neuritis often develop recurrent optic neuritis, and they have a high likelihood of blindness. In older onset patients with myelitis, usually the recovery is poor. But on the other hand, if the myelitis occurs in young patients, the recovery is often good and without permanent motor disability. So age seems to be a prognostic factor. As for race, in comparison with the Japanese population, this is a study done by our group and the Oxford group and reported a while ago. In comparison with the Japanese, white populations had a greater probability of ambulatory disability, wheelchair dependence, and the Blacks had higher likelihood visual disability and more frequently having severe attacks and higher mortality rate. So race may modify the clinical features of the disease. As for the onset attacks and permanent disability, some patients may develop permanent disability by onset attacks, but in most patients, they require multiple attacks to acquire significant permanent disability. But needless to say, early and effective treatment is important for the better prognosis. As for the treatment in the acute phase, as you all know, if the patients fail to high-dose corticosteroid, you start plasma exchange right away. But this study shows that if you start plasma exchange after 5 days of onset of attack, the good recovery rate is very low compared to the patients who started plasma exchange much earlier. So these authors concluded that there was an improved clinical benefit of early initiation of plasma exchange during severe attacks of NMOSD, but importantly, perceiving plasma exchange as a rescue therapy only after steroid therapy could be deleterious. So you have to start plasma exchange right away after the patients experience a relapse, not just after the steroid failure. That, I think, is an important message. Recent research has identified a number of therapeutic targets in the disease. And here's a plasmablast that can produce pathogenic aquaporin-5 IgG. And these plasmablasts are mainly supported by interleukin-6. And these cells are mainly CD19 positive. And aquaporin-5 IgGs are essentially IgG1 and activate complements efficiently. And by the mechanism of complement-mediated cytotoxicity, astrocytes are destroyed. So IL-6 and CD19 complement C5 are the therapeutic targets. And as you all know, 2 years ago, those 3 monoclonal antibodies were evaluated for their risk reduction of relapse in NMOSD. And as you can see here, especially in aquaporin-4 IgG positive disease, there were 80 to over 90% risk reduction of relapse associated with the monoclonal antibodies in comparison with placebo. So there were significant treatment effects by the monoclonal antibodies. But on the other hand, in aquaporin 5 IgG negative NMO, therapeutic efficacy was not evident. What about other prognostic factors? Well, pregnancy is also important. And as you all aware, there's a high risk of relapse in early postpartum period, especially in the first three months. And there's a risk of relapse during pregnancy is not low. An interesting data is seasonal variation. In 2 studies in Asia, Japan, and China, spring-summer predominance in the onset of AQP4 positive NMOSD. Interestingly, a study from Australia and New Zealand showed that increased trend of relapse in November, January, which corresponded to mid-spring to summer in Northern Hemisphere. So seasonal variation may be a prognostic factor. What about vitamin D? Some studies reported vitamin D insufficiency may impact on the disability, but other studies did not confirm the association. Smoking did not increase relapse rate, but may cause worse disability due to poor relapse recovery. So more studies are needed. As for the biomarkers in the disease, Professor Ho-Jin Kim's group of Korea reported that the importance of CD27 positive memory B cell monitoring to prevent relapse. So by the treatment of rituximab, they suggested that the CD27 positive memory B cells should be lower than 0.05% of peripheral blood mononuclear cells in the first 2 years, and thereafter less than 0.1%. If these memory cell B cell population were increased, were higher than these percentage, there was a high probability of relapse. So the memory B cells has a prognostic implication. We previously reported that astrocytic cell damage marker, GFAP, was very high in the acute phase. Please note that these NMOSD patients were all AQP4 IgG positive. And we also showed that there was a significant correlation between CSF GFAP and EDSS score and the lesion length of myelitis. So the CSF GFAP has clinical and prognostic implications. By the way, a recent study showed that the serum GFAP measured by CIMOR technology may serve as a biomarker of NMOSD activity, attack risk, and the treatment effects. So serum and the CSF GFAP seems to be important in considering prognosis of the disease. We also reported that the CSF complement C5a was high during attack, and there was a positive correlation between CSF C5a level and EDSS and contrast enhanced lesions. So to summarize my talk, in AQP4 IgG positive NMOSD, in terms of prevalence, Blacks and East Asians may have higher prevalence than white populations. In Latin America, genetic contributions from Africa and Native Americans resulted in high prevalence. And also the HLA associations are important. And age and race may influence the attack phenotypes and long-term disability. And needless to say, treatment is quite important and have a big impact on the prognosis. And as for biomarkers, I introduced some data on the CD27 positive memory B cells, GFAP, and complement C5a. As for MOGAD, there was a higher frequency in certain population in comparison with AQP4 IgG positive disease. We do not know much about the environmental factors and infections. in this disease. So more population-based studies and the genetic studies are needed to clarify the pathogenesis. This is the last slide, and about 3 years ago, after a European NMO meeting held at a hotel near London Heathrow Airport, I visited Windsor Castle with Dr. Ji-Yoon Ho and Professor Brian Weinschenker. A building behind us, I think, is the St. George's Chapel, where the funeral of Prince Philip was held recently. Dr. Ji-Yoon Ho, as you can see here, is a very young, talented neurologist from Malaysia, and he has a keen interest in NMOSD. So please remember his name. And thank you very much for your kind attention.